All right. So when you should do spine ultrasound, we'll talk a little bit about embryology and some normal anatomy. Also talk about scanning technique and show a few illustrative cases. Some of the indications you might, or reasons you might want to do spine ultrasound would be for multiple congenital anomalies. Sacral dimple, we'll talk about what qualifies as a sacral dimple in a second. That is including location above the gluteal crease. The pit is not seen, that's another considered complicated sacral dimple. From the dimple, another reason why you want a spine ultrasound. Any skin findings. So things like a mass suspected for Spina Bifida Occulta, as we're seeing in this illustrative example, or for determination of a failed lumbar puncture. So they've tried to do an LP, couldn't get it. Now they see what's going on. Is there a tethered cord? Something like that. And particularly helping direct where they might do a successful tap. Just a definition of a question that we often get, what is Spina Bifida Occulta? The actual definition is any skin-covered osseous defect, elements through which various combinations of neural elements as you protrude. That's how you find Spina Bifida Occulta. So if you think about ultrasound, can be used because there's this incomplete ossification of the posterior spinal elements in the newborn. So usually, in my experience, between 0 to 6 months is when you'll be able to see it. Really, to between 4 and 6 months, it can be a little variable. Also, it's a lot more technically challenging because the babies don't really want to stay still for this exam. And so it can be pretty tough. And we have successfully done it in a kid 4 months, but it can be really challenging. There are a few so-called high-risk and others that are low-risk lesions. And we talked about the skin lesions, but some of the things that are at the most high-risk would be atypical dimples, and that would be either greater than 5 millimeters in diameter or 2.5 centimeters above the anus. So those are considered atypical. So again, above the anus, more than 2.5 centimeters or more than 5 millimeters in diameter, something you should have some concern over. Also, angiomas or plasia, cutis aplasia, absence of the skin over that area. Any heritage or skin tags are things to have concern for. Things at risk are just benign dimples, again, less than 5 millimeters in diameter or in 2.5 centimeters of the anus. Those are meant to have low risk, or ones without any skin findings. A brief review about the process of neurulation. Go from the neural plate to the tube, and there's certain steps that we go through going from the neural plate to the tube, and areas where things can go wrong and where we can get anomalies and abnormalities. And particularly as going from the neural groove to the neural tube, there's a step that we refer to as disjunction, where the tube folds over and it has to pinch off. It drags in a little bit of the surface ectoderm, and we start to get abnormalities that will show. And the neural tube, the way it folds, process of neurulation, it happens from the center, kind of like a Ziploc bag. It zips on the sides. Then 30 days of gestation, there's another process here. Canalization here with this posterior cell mass blob tube here. During this process is another area, another step where things can go wrong. Microcysts that form into the caudal cell mass, and then the neural tube. Canalization. Then another step, retrogressive differentiation. So this is another step here where the caudal cell mass, when they regress, the neural tube regresses in size. And then you form some of these more recognizable structures, the fetal conus medullaris, ventriculus terminalis, finale. During this phase is where things can go wrong. This technique is a few things that we do. We follow the ACR practice guidelines. This is the American Radiology guidelines. I like to have a warm room, mainly because it just keeps the babies more comfortable. They're not as apt to move around. Really fed or potentially giving them a pacifier that's dipped with sugar water, sucralose, calm, and keep them still enough to do a good exam. Positioning, we have this example here with towel under the baby that opens up the posterior spinal elements with the knees flexed. The baby can separate elements. We can also do it in an alternatively left lateral decubitus position, but this is the ideal position if you can do it. So here, if the baby can't tolerate being prone, we can do it in this position as well. I want you, though, to label your images left lateral decubitus as you're acquiring them, but it can be confusing to anyone reviewing them afterwards if you don't know that the baby was positioned that way. So ideally a high-frequency transducer, and as high as you can find. So basically, up to 15 linear is what we generally use. If you're looking for superficial lesions, you want to have a standoff pad. I used the standoff pad using just a glove and filled it up with water and tied it off. So there's definitely it's doable. And ideally, what you would be using was a standoff pad like this that gives you a little bit of separation between lesion and your transducer. So what are they for? You want to look at the cord, the caudal, back, swing space. What I do, the way I acquire this, usually I start off with a transverse image of the cord. I just do a sweep superior to inferior along the spine, and that gives me a very good overview, first pass look through what I'm going to see in the spine. Next, preliminary longitudinal views. This will just give me an assessment of where I think the conus is going to be right off the bat. Is it very abnormal, or am I probably going to be looking at a normal structure? About how we can do the numbering for this to what level the spinal cord is. Numbering, we can do this. There's a sonographic method that we don't have methods to do extended field of view imaging depending on what you're working with. Here is with an old Accuson. When I was first learning, I learned on this. Where it's a very good way to do extended field of view imaging. And we just had to do a split screen and try to match it as best we could. It was an idea. The important thing is to try to figure out how I'm going to number the vertebral bodies. Talk about a few ways to do that. There are three basic ways to do it. The way I find is most reliable with the ACR practice guidelines say is most reliable is to find the L5-S1 junction. And S is the first vertebral body to angle up. So here, just a moment, the lumbar vertebral bodies are going straight. The first to angle up, that's S1. We're going to that. That's the most reliable. There's other ways, so for instance, using the T12 rib and sliding over and then saying, okay, that's T12 and numbering down. There can be variable number of ribs, so that can be less reliable. And to use the sacral ossification centers from the instrument count up. So there should usually be 5 sacral ossification centers. The challenge is that the number of sacral ossification centers can be variable as well. We'll show you some tricks on that. So for my numbering, this is what I use, and this is the thing I think is most reliable, is this lumbosacral junction. Being one potential use, looking at ossified segment and then counting backwards. Again, that's variable. Ossification is less reliable. This is one way you could do it. To tell you that you might be getting faked out is that the sacral ossification centers are rectangular, where if you do have an ossified coccygeal segment ossification center, it's really round. So one logic difference it can tell you, I'm not worried, I'm not seeing a sacral ossification center. If you're going to use this method, this one thing to look for is that, again, sacral ossification centers, rectangular, phalangeal ossification centers are usually round. Evaluated cord motion and the motion of the nerve roots. A few things you can use. One, just visually watching real time, and what you're looking for the nerve roots to just very soft motion of like seaweed in the ocean floating around very nicely. Or you could use M mode. This is another way to use this to show that you've got motion of those nerve roots, showing you that the cord isn't tethered, it's not stuck down there, and you're seeing normal motion. You can also loop, but showing the normal respiratory motion. Again, this is often why I refer to this study in the first place, and that's the evaluation of the sacral dimple. So first we'll talk about this in a moment here. Anatomy overall. Let's go now some of the important anatomy first. So when the first one to turn up, that's S1. Then, okay, L2, there's L2. Right there at the very bottom of L2, L3, any lower than this. This is kind of my lower limit of calling within range for this. This is at the L2, L3 junction. Really don't want it below this level. So Subdural is the dura, here's the Cauda equina. This is pop quiz here. We'll just say, we'll skip that part for now, but basically this is pointing to what this echogenic area, even though it represents the central canal, is actually to the interface of the anterior median fissure. It's just a atomic structure that's actually what's giving the echogenicity. But I use this as a marker to tell me, okay, I'm looking at the spinal cord and the canal. To be aware of, this is a coccyx, the dysmorphic appearance of the coccyx here. We can see that this coccyx can vary. Normally, it should just be going the opposite direction. Sometimes kind of point up like a little tail. Make a mass, though, they can feel on exam this hard structure here that they're afraid might be some kind of a tumor. It's usually just this normal variant. Again, this normal one should look like it should have this type of sloping like this. Here, this is a ventriculus terminalis here within the actual cord here. It's an embryologic remnant of that fetal process we saw, retrogressive differentiation. So, again, just something to be aware of, a normal variant. Can sometimes be tricky to see on a again, amazing, but usually nothing to worry about. Now, if we're going to scan the baby at a left lateral decubitus position, that we ideally want to label our images as such. Because if we were looking at this and we didn't know that, we think, wow, there's some tethering of the cord, or there's maybe a mass here. And respecting the cord and all the all differently. And so it looked pretty funny if we didn't know that it was scanned like this. All right, so a quick quiz here, just within the lecture. What is associated with gastroschisis, complex, or of diabetic mothers? Infants, I just made up cadre complex. There's no such thing as that. All right, I know. Caudal regression syndrome. Let's talk a little bit about that. Not uncommon, particularly children with diabetic mothers. Other GU anomalies, anomalies. So that's again where you see essentially just an abrupt termination of the cord here, and you'll see sacral anomalies in particular with this case of regression syndrome. Intradural Lipoma, that's another thing that we can see, and we talk step of disjunction and where that goes from the neural tube, and where things can kind of get pulled in, and this is one example of that in this intradural lipoma. Ligament gets trapped here. It's usually normal fat. To point out this thing, it's called a Filar Cyst. It's a variant, no clinical significance. Challenging to see on MRI. Eminent filum, but around 2 millimeters or less. We'll leave it alone, but this is an example of a prominent filum. Compare that to the tethered cord, which is measuring more than 2 millimeters in this case. Here we have an example on an MRI where we see the fatty filum in this case of a patient with tethered cord. And we can, number-wise, that the tip of the conus is now around L3, so it's below that limit that we'd set for on the other example. That in and of itself isn't necessarily anything that you is a slip for tethering. It is to keep in mind, but it's also seen in normal patients. Again, asymptomatic and actually seen in 6% of normal spines at autopsy. But when isolated, it's considered a normal variant. That can be associated with including the tethered cord. So often, necessarily do ultrasound imaging for is the lipomeningoceles or these meningoceles, often received at MRI because the ultrasound I consider more really of a screening. So one row, either I see something totally normal or I see something abnormal, and I'm going to go to MRI from there. Often in these cases, this goes straight to MRI examples. So for example, one thing to look for, this is a dorsal dermal sinus tract. So this is the reason that we get MRIs for ultrasounds for these dimples, looking for something like this, where we see they've got it's just the tip of the iceberg, showing that there's a tract that goes all the way down and communicates with the spinal cord. As a result, we have this huge associated mass, which often happens, often hemangioma or a dermoid or a lipoma. Another you can see this is an example of a subdural hematoma. This may have been an attempted tap, and it was successful and related to and resulted in a hematoma. Super common. Often when it happens, it's iatrogenic. The answer with ultrasound that is the sacrum press and level for them to try again if they really need to. This example is just an example of how we might use ultrasound. The newborn with the right leg not moving, we need an ultrasound here, and see that this very large mass, it's quite vascular, complications within it. So we gave a little differential. We said it could be a teratoma, could be some kind of a nerve sheath tumor like a schwannoma or something like that. Very uncommon though at age. And then there are a few things like hemangiomas that we can also see. So what I'm do is an MRI. And with a dumbbell-shaped thing, you know, it kind of looks like a schwannoma, but these are very uncommon at this age. Angioma. Something more common can be seen in spine, so that was a spinal hemangioma. Here's a quick case. Shotgun barrel pair of the spinal cord. Yeah, what am I going to say? Anyway, so diastematic is a few things that it can have a bone bridge between the two, or it can just be separation. Each one of them will have their own individual nerve groups. All right, nice reference is sonography of the neonatal spine. There's both a part 1 and a part 2 that is really helpful. And there's part 2. All right, so we've talked ultrasound and pathology. We've talked about spine ultrasound, normal anatomy, and cases, and that's about it.